Yeah.
Here, like if I was going to say in the Hauser Neck Center, or the cases we see here at Caring Medical Florida, is probably the most common complaint as far as head issues we get now is actually head pressure. There's people that come in and they just have this unbelievable head pressure that won't go away. So if a person goes to doctors and they give them a bunch of medications and no medication can get rid of their headache or head pressure, it has to have a structural cause, because the structural cause isn't going away. And the number one structural cause that we find, because we test for it, is compression of the jugular veins. So the jugular veins are the main drainage port for the brain. 70% of the fluid in the brain is in the venous system. So the jugular veins are like humongous, and all the other veins that drain the brain, they're like teeny weeny. So if a person has a breakdown of their neck curve compressing the jugular veins, and that compression could even be, when they're laying down. Because think about it, like if you went to a doctor and you said to the doctor, I'm telling you, when I lay down, the head pressure doesn't go away. I would think, unless the doctor knew about how the structure of the neck affects the brain, that would be perplexing for them, because most of the time head aches do get better when you lay down. So if you have head pressure and it doesn't get better when you're laying down, you have a significant breakdown of your neck curve, and you need to get at least a lateral x-ray to show that the neck curve is reversed, and perhaps get a digital motion x-ray to show instability. So now when you research intracranial hypertension, the old terminology was pseudotumor cerebri. Pseudotumor means like a tumor, cerebri, so the effects of like a tumor. And a tumor is a space-occupying lesion in the brain. Like if you have brain cancer, it occupies space in the brain, and the brain is limited, so the pressure in the brain goes way up, and you get head pressure, you get nausea, you get dizzy, you feel all these things. So pseudo, it's like that. The new terminology is idiopathic intracranial hypertension. It's called IIH. Well, idiopathic means they don't know the cause. Well, I think we know the cause, and the cause of it's ligamentous cervical instability. I like this. This is actually from an old time article. So, I guess it's in 2016. I thought it was older than that. But basically it just shows that when you have venous tension, in other words, you have venous distension in the brain, there's various headaches that are produced. So look, this is on, basically right here, this is right here. So I have this up here just to show that if you have compression of the jugular veins, that's going to cause venous hypertension in your brain. It could cause any kind of a headache. Not just a whole head pressure, but any kind of a headache.
Most people don't say, my entire head hurts equally. A lot of people have certain parts of their head that actually, like that's their common headache, or that's what usually hurts more than other areas.
So what we normally find is if you just have it on this side, we're mostly going to find jugular vein compression. And how we test for that is we actually do jugular vein measurements with high definition ultrasound. So why don't you go through all the different things when you get intracranial hypertension or jugular vein compression? Lots of symptoms.
Lots of symptoms. So headache, of course, like you have all this increased pressure in your brain, but even eye pain, you alluded to this before, if the fluid is not draining, it's going to go somewhere, right? That fluid is going to actually build up behind your optic nerve in your eye, which can actually cause some eye pain. If you have, again, a lot of fluid floating around in your brain that can't drain out, you might feel kind of dizzy. People get anxious, their vision gets distorted. All of these things too, which can also cause anxiety, on top of all of that, if you don't know what's going on. People that kind of feel seasick, depression, especially
personality change.
Even maybe not even related to that, but just with everything else going on, that really can take a toll on your mental health. Brain fog, focusing issues. I recently had a patient who, she was an Ehlers-Danlos patient, so just very naturally flexible by nature. She had upper cervical instability, and she's working on her curve. But this is what she told me, and I quote, she said, "I'm too dumb to function," or "I'm too dumb to work." That's how she actually felt, was she could not concentrate. She really couldn't perform at the level that she was used to. And it's funny because I saw her after I came back from being gone for some time. I said, "How do you feel?" And she said, "I finally feel smart again. Like I actually feel like my brain works because I've been correcting the instability and working on my curve."
Yeah, currently I'm treating either 3 or 4 medical students. They actually had to take leave of absences.
Wow.
Yeah. Because, we have talked often in that, like, let's just say somebody's a loose jointed gal, then to get into med school, like the amount of studying you would have had to do in college is enormous. So you're like, doing this all day, and then at some point the body can't relieve the pressure anymore. So the body tries to relieve the pressure, and it does so by having the fluid go out the back of the neck in what's called emissary veins, and then they work their way back to the jugular veins, which take them to the heart, and it goes in circulation. But that can only handle so much fluid.
Sure.
And then eventually the body has no more compensatory mechanism, and that's when like the symptoms get terrible, like you just said. Like they can't do the medical school work.
Yeah,
and
it's
then
too much.
But fortunately in our country, when medical students have trouble, they give them a leave of absence, and then one of the patients, 1 out of the 3, is now back in medical school.
Wonderful.
And this is the non-invasive way that we document intracranial hypertension by, you can see how swollen the eye nerve is there.
So this is the eyeball.
Yeah.
And this is the front of the eye, and then here in the back is that optic nerve out the back. So these are ultrasound measurements, simple ultrasound, non-invasive, non-painful, to look to see how swollen this one is.
Yeah, so normally anything over 6 millimeters. Some of the research that I've read, that optimum is probably in the 4s, and most of our patients are in the 8s. Like so abnormal. It's so abnormal. And then I've said this multiple times that personally I think brain disease or atrophy of the brain that we see on MRIs, I think it's because there's too much brain pressure. So I fret that if people don't take it seriously, this looking down at cell phones and looking forward, that if I'm correct, that jugular vein compression is the number 1 cause of intracranial hypertension, and intracranial hypertension is the number 1 cause of brain atrophy, then there's going to be just a crazy amount of dementia. So if somebody doesn't want to have Alzheimer's in their future, I'd really encourage them to make sure that they maintain the neck curve by making sure that you look up instead of look down at screens, and perhaps get your optic nerve sheath diameter checked. When there's brain venous sinus outflow obstruction, basically we just call it the brain toilet is obstructed, and the way to unobstruct it is to get the neck curve good. And then if there is instability present, you might say, well, at home, how would I know if I have instability present? If you have some of these symptoms that we talked about, but you feel better when you're laying down, and then when you get up, a lot of times they can't hold the anatomy. So in other words, a person gets up, the weight of the head's here, the atlas goes for it, then it obstructs more, then you get worsening of the symptoms. So that would be a sign that you have cervical instability. It's not 100%, but if you have, like, you lay down, the jugular veins are more open, your brain pressure goes down, you feel better, but then when you get up, because of instability here, the atlas goes forward, then you get kinking of the jugular vein, and then you get an increase of symptoms.
You often have said this to patients, and which is just great advice, and even maybe for people that don't have neck instability, but if you're someone that works on a computer a lot, or you're on your phone a lot, maybe for your job, and you're constantly looking down, every hour, every 2 hours, just lay down. Take time.
5 minutes.
Yeah, take time looking up, or lay on a pillow that's a little rounded, just to help facilitate that curve and help to drain your brain, by those jugular veins. And it actually, like I've tried it myself, and it makes a big difference. If you're, on a project or something where you're on your computer for a lot, just reminding yourself to do that can be very helpful.
Yeah, especially if somebody's on the verge of they might have to give up their job. Before you do that, just lay down for 5 minutes every hour, and you're not cheating the boss, like if you work from home, because you're going to be so much more productive the other 55 minutes. And then there's a lot of things we could talk about as far as the internal jugular vein. When you compress the internal jugular vein, the flow through the vertebral arteries, and like I said, the emissary veins, it goes way up, but it can't keep up because the jugular veins are so much bigger, and that's why we tend to measure them. The jugular veins are supposed to look like this. When they look like that, see, when they look like that, all the flow goes to the back. And when you do prolotherapy under guidance, when you use that ultrasound, isn't it true? You see those big veins. Like, you think it's an artery because it's so big, but then it turns out it's a vein.
A lot of times patients, their symptoms are more one-sided, right? So you might see more jugular vein compression, let's say on the right side. Well, then when you go to do prolotherapy at that right, like C1, C2, you'll see way more blood vessels, way more blood flow than you do on the other side. I feel like it's always that way.
Yeah, so that's like confirmation that the person has a block here and then the fluid. And then the other thing too is you could have humongous lymph nodes on that side. We had one of our patients who had jugular vein compression at multiple areas. They were a pole vaulter, so they had a lot of fibrous tissue, so we got them like 50% better. So the doctor in the operating room, this was just last week, they actually had to take out some of the lymph nodes. Like, the lymph nodes were so big from the blockages because the fluid just looks for any way, and it's actually called the veno-lymphatic system. So if this is blocked, it might be the lymph nodes. So if you're somebody who has like this humongous lymph node, it might be just from the jugular vein being blocked. So the person actually had several of their lymph nodes taken out because the lymph nodes that were blocking the jugular vein. So this is basically, what we do. We measure the jugular vein, and then we take all kinds of measurements of the jugular vein in different positions. And then we can tell what sleeping position. Like, the best sleeping position for me is on my side, looking up, especially my right side, because I have a styloid, which we'll talk about, because sometimes the jugular vein is getting compressed from styloids.
One question that we always ask that you taught me is, does the patient feel better first thing in the morning? Because if you're sleeping well, and you're laying flat and you're not putting any stress on your joints, you should wake up feeling well. Maybe then your back hurts as the day goes on, or your knee hurts as you're on your feet a lot, or your neck starts to hurt as you kind of slouch into that posture. So if you don't wake up feeling well, we can kind of find out why. Maybe you're not sleeping in a really great position that's allowing your brain to drain overnight, and you just wake up feeling crummy.
The other thing too we'll do jugular vein measurements when they're upright. It's amazing. Like, somebody's like this and they're all closed off, then we just say, hey, look up a little. Then they open up. I mean, it can make a major difference. So if you're somebody who doesn't have your computer up, we'd really encourage you at least to try that, and then lay on your side. Now, we also do cone beams. So we do an upright digital motion x-ray to look for instability. Then we do these cone beam CT scans. Part of the reason is about 75% of the patients that come to Fort Myers to see us, they have styloids that are impinging on the jugular vein, or at least the styloids have become elongated. So I just want to talk a little bit about that. So in this study, the normal side, the atlantostyloid interval, so here, see how this model has a styloid here. So the styloid is normally supposed to be this big. It's not supposed to overgrow. The styloid is the attachment of some significant ligaments, like the stylomandibular ligament. There's some suprahyoid muscles that attach there. But when you go like this and you're like this, there's tension on that stylomandibular ligament. So an elongated styloid is actually a calcified ligament. So they showed that on the normal side, the atlantostyloid interval was this, but on the side with the jugular vein obstruction, it was 4.1 millimeters. So the atlantostyloid interval is the distance between the basically the lateral mass or the transverse process of the atlas and the styloid bone. So we've basically found this too, I've said this many times, that as long as the atlantostyloid interval is over 7, the person usually does fine. When it's like right next to each other, that's when we might consider that the person either should get a referral for a styloidectomy, or we'll do 3 or 4 prolotherapies with curve correction. Now, because most people have a forward atlas, the forward atlas can narrow the space regardless of the styloid. Now, if a person has a styloid causing a problem, then it's likely that when they flex or look down at their cell phone, they're going to have more symptoms, or if they rotate their head. So I have a styloid on my right, so when I rotate to the right, I can get some increased symptoms. And I look at elongated styloids as a blessing, because most of us know we're not supposed to be addicted to our cell phone and looking down. So when you have styloids, you just can't be looking down, otherwise it's going to compress the jugular vein, and the jugular vein goes into the jugular foramen. So what else goes into the jugular foramen? That's significant.
Your vagus nerve?
Yeah, the vagus nerve. The vagus nerve, it innervates all the internal organs, the lungs and the heart. So when we say that a person has jugular vein compression, we're really saying you most likely have vagus nerve compression, and you have glossopharyngeal nerve. The glossopharyngeal nerve is the blood pressure sensor. So anyone with POTS or dizziness, and what we'll do in the office is we'll stick a tongue blade in the back of the throat, and it's amazing how many people don't have a gag reflex, which is a sign that the glossopharyngeal nerve, which is the sensory branch of the gag reflex.
I actually had another Ehlers-Danlos patient, different female, who I haven't seen in years, since I worked at the Illinois office, but she came back down here to see us, and she had terrible POTS, like just very bad symptoms.
They get up from the laying position, they get up and they get real dizzy and they get tachycardia. That's what POTS is.
Yeah. And at that time, we did a whole round of prolotherapy, like her neck got stable. And when I saw her again, she came to see me for her pelvic floor. We were just talking about it, and she said she's cut her medication dose in half.
Oh, great.
For her POTS. So that was pretty cool to hear.
Amazing. The other thing too, the medications they use, they're beta blockers, and because beta blockers, they slow the heart rate down. In my residency, when I was in residency in medical school, we used to call those the main medication that was a beta blocker was Inderal. We would call it Endidol.
Oh my gosh.
Because you don't realize, like, a lot of the joys of life is like you get excited and your heart rate goes up and you and you're playing around with the kids, and you don't realize, like, it's Debbie Downer. It's totally Debbie Downer. When you're on a beta blocker, there's almost like a low-level depression that occurs in a lot of cases, because it's kind of like a sympathetic sedative.
Okay,
right?
yeah,
You can't you don't realize, like, how much of life you just want to get your heart rate up and So people feel so much better and mentally when they get off a beta blocker. So anybody with POTS, man, I would just say you're going to feel so much better once you get rid of the POTS and you mainly get off of that medication. And then, we sometimes do venograms. So somebody wouldn't get a styloidectomy, or a surgeon wouldn't do a styloidectomy without. And this just shows, like, look at it. This is the atlas, and they're flat as pancakes. Like, the jugular vein's supposed to be round. Like, look at that. They're totally flat. So these are the styloids. So we use a venogram sometimes, and that's where they inject contrast, and the person's laying down. It's done at the hospital or some of the radiology centers. So we can tell whether it's the styloid or the atlas causing the compression. And if somebody has both, like it's the styloid and the atlas, we would tell the patient, well, you have really long styloids, and we do feel like they need to come out. But because part of the compression is from your atlas, even if you get your styloids out, you're still going to need to do curve correction and prolotherapy. And then depending on how bad the compression is, we'll decide whether we send them for a styloidectomy or we just try more conservative care first. And this is the 3D rendering, right? So what does that show?
So this right here, if you see this long bugger right there, that's an elongated styloid.
Yep, and then what's that?
This is the jugular vein.
Yeah.
So here's the jugular vein coming up. You can see it's like thick, 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 and then it gets really thin right here before it kind of thickens again. So where the arrow is pointing is where that jugular vein is getting kind of kinked, and then this right here is that most lateral part of C1 behind it. So you can see the jugular vein between C1 and then that long styloid. It looks like it's because of that C1 touching it.
Yeah, so this particular patient, it's really the atlas. So you wouldn't get a styloidectomy or anything. And then these are some of the, when we do ultrasound, so that's how the jugular vein's supposed to be. And then there it's completely compressed. So say somebody's laying down and it was like say they laid down and in their current sleeping position, because most people sleep curled up and flexed. So if somebody had a breakdown of the cervical curve and they're sleeping while they're flexed, the jugular vein may be like this or this. So their sleeping position is causing them to have intracranial hypertension. So we figure out what sleeping position is going to get them more like this. And sometimes we just have them lay on a dinner roll or something that induces a cervical curve. And if it opens up a lot, the jugular vein, that's a sign that if we just help them get a good cervical curve, then their drainage of their brain's going to be a lot better. So when you get a venogram, it will show all these. And I've only had, I think, 1 or 2 patients in the history of me ordering venograms where they actually had a stenosis. So one of our patients had a transverse sinus stenosis, a transverse sinus, and then we sent her to like a neurosurgeon, and her symptoms weren't that bad. So we're causing the relief of the jugular vein compression. I know this is getting better. So it's interesting because it might be even if you have an intracranial venous stenosis, there may be a non-surgical way to relieve it. So that would actually be a reportable case, because normally when you have stenosis of a vein in the brain that's causing intracranial hypertension, you normally have to have neurosurgery to stent it or whatever. So this shows that there's compression, jugular vein. Then when you get intracranial hypertension, on the MRIs you can see where there's extra cerebral spinal fluid, like in the frontal lobe area. So you can get frontal lobe atrophy. In the frontal lobe, that's like your intelligence center.
Wow.
So that's one of the reasons why people, they just feel, like you said, they're getting dumber. Then you get flattening of the pons, and we did, one of the videos we did was on the trigeminal nerve, which originates in the pons. So you can get compression of the pons, so that's not going to be good for all the nerves that originate from the pons. I know right now I am treating one patient with cerebellum atrophy, because you can see all the fluid here, cerebellum atrophy, I can't say one way or the other if it's going to work or not, but at least theoretically the patient knows that there has to be something causing their idiopathic cerebellar atrophy, and it may be that it's just intracranial hypertension from jugular vein compression. And then the next part, we're going to talk about how to treat it with prolotherapy. So we're going to show some an animation of prolotherapy, and then at least one procedure, maybe a couple of procedures. Okay. So thank you guys so much for watching, and look forward to the next time where we can talk about the treatment of the headaches with prolotherapy.